next year. So today what I'm going to talk about is antiphospholipid antibodies, APS, and recurrent pregnancy loss. I can advance the slides here. Okay, my disclosures. So antiphospholipid syndrome, as many of you probably know, is a systemic autoimmune disease mediated by circulating autoantibodies. It's a heterogeneous group of phospholipids and phospholipid binding proteins. The major clinical manifestations are thrombosis and pregnancy complications, and there's a wide variety of other clinical manifestations as shown in the diagram on the right. And because of all these other manifestations, diagnosis can be challenging. And recognition of APS is important because up to 20% of strokes in individuals less than 50 years old can be attributed to APS. And as you well know, it can contribute to recurrent pregnancy loss. And if the APS can be identified, then it can be treated and you can have successful pregnancies. So one of the things I had looked into, antiphospholipid syndrome has never been a really big area, but it's over the last several years, it's continued to gain interest. So here I show at the top here, this shows the number of publications related to APS has been increasing over the years. And if you look here, here's the worldwide distribution of where papers come from. And if you look at the publications on APS, China is actually listed as number 6 in the publications in the area from 2012 to 2021. And here I have two things I extracted from PubMed showing the number of papers on recurrent pregnancy loss has been increasing constantly until the present point here. And the number of papers appearing on recurrent pregnancy loss and biomarkers is also increasing. One of the things that's important to realize is that antiphospholipid antibodies are not a single entity, but are really a group, a spectrum of different antibodies. And these antibodies can be found in a number of different conditions other than just APS. So I have here antiphospholipid antibodies, obviously present in APS, but you can also find them in infectious disease and cardiovascular disease, SLE, and other conditions. Now, often these are low titers, and this is important when we get to the classification. This is why low titers have to be viewed suspiciously because they may indicate other diseases going on. But the other thing is that because they're present in other diseases, when they started to do research studies on APS, the presence in other diseases complicated the studies. And so it was determined that we needed to have some sort of classification criteria to determine when patients truly had APS. So after a 1996 meeting on antiphospholipid antibodies in Sapporo, the 1999 Sapporo classification was developed. And then in 2006, this was revised, and it was called the Revised Sapporo Classification. And just a few months ago in August, the ACR, American College of Rheumatology, and the similar European meeting, EULAR, came up with a 2023 classification scheme, and I'll talk about that later. But as I'll point out, there's still some limitations to this new classification, and they do even admit this in the classification. So there will be another classification criteria coming out in the future, and hopefully not too far in the future. Okay, so what people usually use until a few months ago is called updated Sapporo classification for APS. So in order to be classified as having definite APS, you need to have one clinical criteria. It could be thrombosis and or pregnancy morbidity. And you have to have a laboratory criteria, persistently positive, lupus anticoagulant, anticardiolipin, beta-2-glycoprotein G or M, added at medium or high titer. And if you have at least one clinical criteria and one laboratory criteria, then you could be classified as having definite APS. However, I'll mention it multiple times, but even if you satisfy this criteria, even if a patient has definite APS, that's fine. But you may have patients with APS that don't fit the classification criteria and therefore won't be classified as APS. So I think one of the most critical points that we'll be making, and I'll probably make it multiple times, is there is a distinction between classification and diagnostic criteria. So the classification criteria, if you read all of the papers including the most recent one, they emphasized repeatedly the classification criteria are designed for research. They're intended for research studies. They're not intended for diagnosis. The diagnostic criteria for real life and are designed to detect all the patients with the condition and provide treatment. So in the table I have below here, we have the goal of the classification criteria is to have standardized, well-defined definitions to ensure clinical research studies have uniform cohorts to optimize study results, conclusions, and comparability across studies. In contrast, for diagnostic criteria, you will have to look at the signs of broad set of signs, symptoms, tests for routine clinical care to guide the clinical decisions for individual patients. So in the classification criteria, you want a homogeneous representative population of patients with unequivocal APS. The diagnostic criteria, obviously, you have people with all sorts of heterogeneous. You have people with all sorts of symptoms, all sorts of antibodies. There's various presentations. For the classification criteria, the goal is very high specificity because they want everyone that's classified as APS to definitely have APS. They don't want they specifically exclude anybody with doubtful APS, with potential APS, any sort of equivocal things. They only want unequivocal APS. Whereas diagnostic criteria, you want to be able to detect all the people. So high sensitivity, high specificity, but you have to make sure it's sensitive enough so you don't miss patients who then won't get treated. And treatment impact, obviously for classification, there's no specific impact on treatment, whereas diagnostic criteria, clearly they do impact the patient's treatment and guidance. But again, this idea, failure to meet classification does not rule out APS. The updated ACR-UR 2023 classification criteria. So the goal was to make it a more stringent methodology, use data-driven, expert-based approaches, using new analytics to develop a better, robust classification criteria for improved homogeneity for APS research. So they did, one of the things, they did expand the clinical and laboratory criteria. Well, they expanded the clinical criteria to incorporate new findings. Laboratory criteria, they didn't really expand very much. But the whole goal was to improve patient care and management. But again, the primary design focus repeatedly in this classification was for specificity. The new classification has increased specificity, as we'll see, but lower sensitivity. It's used only for if you use only the classification criteria, you will miss patients with APS. So if you go through I don't expect you to read the fine print here. You can go to the final paper, but the new classification criteria starts with the entry criteria. And this is essentially the same as the Sapporo revised Sapporo, which you need to have at least one documented clinical criteria, which is listed for a big list from on the next slide. And you have to have a positive laboratory criteria. Antiphospholipid antibody, lupus anticoagulant, moderate high titers of cardiolipin beta-2 glycoproteins within 3 years of the clinical diagnosis. Now, important here, it says if you don't meet these criteria, this entry criteria, then it tells you to stop, to not apply the classification. So it means that if somebody's using this for diagnosis and they don't have this thing, they will not go any further in this scheme. So the one thing they did expand in the new classification criteria is they did expand all the clinical domains. They made these 8 different domains with more clinical features that were not included in the 2006 Sapporo criteria, and things that people wanted to have. So a much more description of microvascular changes, cardiac valve changes. So this is now included in this clinical criteria. And one of the very important parts of this is they now have weighted scores for each of these, because we know that some of these things are more important than others. And so this now means that you can now generate a score, and it takes into account which things are more important than others. So one of the places you can see this is that for the IgM isotypes down here with the red arrow, you can see they gave it a score of only 1, because IgM tend to be one of the least important in this criteria. They still can be important and important more, and maybe a little bit more important in actually recurrent pregnancy loss and obstetric APS, but in general, they have less value than the other markers. And the other thing is they they included now is that if you have high positive cardiolipin and beta 2, this is considered extremely important. So this has the highest mark of everything. And this is a trend in general that you see with a lot of autoantibodies and markers, that when you have more than one thing positive at high titers, it's now given more clinical confidence, more clinical credence that it's of its significance. And at the end of this day, you add up the number of points. If they have greater than or equal to 3 points from each of the clinical laboratory domains, they're classified as having APS for research purposes. And again, all of this classification says it's for research, not for diagnosis. So if you now look at the sensitivity specificity of the new criteria, the goal was to maximize specificity and identify definite APS. They say, quote, emphasize specificity over sensitivity. They want homogeneity for the patients. They don't want to misclassify patients that get into clinical trials with drugs and potentially bad effects if they don't truly have APS. They excluded patients with whom clinical agreement on definite APS could not be achieved from the steering committee guiding the study. So if you look at the new classification, 2023 classification criteria for the specificity, they did 2 cohorts, a training and a validation. Specificity was great, 99% in both. The sensitivity was 83%, 84%. And if you compare that to the revised Sapporo criteria, the specificity in Sapporo was significantly less, 91%, but the sensitivity was 100%. So again, you're missing patients, but you're making the patients you do classify as definite APS, it's a much higher specificity, which is what was the goal for this new classification criteria. So just some of my thoughts on this new classification criteria. Again, remember here, this green circle here are all the patients with APS. So diagnostic criteria, you want to detect all of these patients. Classification criteria only detects a subset of these that meets all these various criteria. So while the majority of patients may meet criteria, especially with expanded clinical features, many of these patients won't meet it. And it's also important to realize that not everyone agrees with these conclusions. I know from talking with people that were involved with this, that there are a number of them that didn't agree with the final votes on these things. And there's one recent paper that's already appeared in just this month that gives their thoughts on the classification criteria. And I know of a number of other papers that people have submitted talking about their misgivings about some of these points. So some of the unsettled controversial points that PSPT was not added as a criteria marker, despite worldwide support, multiple studies, meta-analysis. This is strong dissatisfaction by many with this decision. The guidelines admit that PSPT may be useful, but say more data and research is needed. IgA isotypes were not included, although they acknowledge they may have value. And one of the points they talked about, only cardiolipin beta 2 ELISA should be used for classification, right? Vendors, classification, not diagnosis, because in their opinion, thresholds for moderate, high ELISA values were not well established on newer technology. And so this can be argued by various people. There are obviously lots of people that are using this, but anyways, that was their conclusion of their analysis. They acknowledge that the newer chemiluminescent CIA labs may be better and more accurate, but still encourage more studies. And I do know there are a number of additional studies on threshold in progress by various groups. But one of the most important things is this is limiting it to ELISA ignores the real life clinical laboratory realities that more and more labs worldwide are using chemiluminescent because it's more accurate, because it has a higher dynamic range. As I showed here, people don't always realize the difference. Here we have ELISA with a relatively small dynamic range. Chemiluminescent has a huge dynamic range. So you can't extrapolate the numbers from this directly to chemiluminescence. But because of this, it has extremely high dynamic range. It can be more accurate. But this is what their conclusion was at the time. So here, if we now go to just, again, we can apply the classification to real patients. So these are patients from Savino Sasha, who's a clinician in Italy. So these are 2 of his patients. This is a 32-year-old woman, 2 miscarriages, low platelets, libido reticularis, 1 stroke, labs, lupus anticoagulant negative, cardiolipin negative, By the Sapporo 1999 criteria, no APS. With the updated Sapporo criteria, which included beta-2 glycoprotein, she was positive, so now she's considered APS positive. If you go to the next patient, this patient is a 36-year-old woman, one stillbirth, one unprovoked pulmonary embolism, counseling a new pregnancy, lupus anticoagulant negative, cardiolipin negative, beta-2 negative. By the updated Sapporo criteria, she's still negative. If you do additional testing with the so-called non-criteria markers, which essentially is everything that's not in the criteria, the IgA isotypes for cardiolipin beta-2 are positive, beta-2 glycoprotein domain 1 was positive, PSPT was positive. So by all of these criteria, you would think she would be classified as positive, but even with the new 2023 criteria, she's still, quote, negative as far as definite APS. So if you want to detect all the patients with APS, you have to look beyond just the classification criteria. So this is a study we did in Shanghai at Beijing Hospital. And you can see here, these are all the APS patients, 186 APS patients. And you can see here the various APL markers. And what I have here box are the non-criteria markers, PSPTG, PSPTM, cardiolipin A, beta-2 IgA. And you can see there's a high prevalence of these markers within the APS patients, in addition to the classification criteria of cardiolipin G, M, beta-2 G, and M. And what's more important, and just to show the effectiveness of PSPT G and M in this, that 86% of these patients were positive for either PSPT G and or PSPT M. What's more important, here's 48 patients that are called seronegative APS patients. So they're seronegative because they're seronegative for the criteria markers, not that they're seronegative. And what you can see here is the PSPTG, PSPTM collectively identified over half of the patients with SNAPs, clearly identified them. And also the beta-2 glycoprotein IgA also identified some of the patients. So essentially you picked up all of these patients, picked up half of these patients by adding these other markers. And one of the things I always try to show, and it's important to keep in mind the overlap of all these patients. Now, in this particular study, it was very clear that the PSPT G and M, it picked up 23 patients that weren't picked up by any of these other markers. So you can see that the APS criteria markers, non-criteria markers, these are the non-criteria markers in APS patients. And you can see that in this particular study, also raging, that 93.5% of the patients, of the APS patients, so these are criteria positive, were positive for greater or equal to one non-criteria marker. So just using the non-criteria markers on their own worked extremely well. And if you looked at, if you looked at the patients that were seronegative APS, there were 90 patients, and almost 60% of those patients could be detected using the non-criteria marker. 60% were positive for greater or equal to one marker. So essentially, there's no reason that these patients shouldn't be diagnosed. And again, we're not talking about classification, we're talking about diagnosis. So it's important to identify these patients. If you then look at the performance of these patients, you can see that again, of these 192 APS patients, 90 seronegative, plus all these controls, of all these tests that were done on this ROC curve, that the AUC, the area under the curve for the beta-2 glycoprotein IgG by chemiluminescence, was the highest performing test of 0.875. It was followed by the PSPT-G ELISA, which is 0.836, and then the cardiolipin G, cardiolipin A, beta-2 domain 1. So some of the issues when we're talking about obstetric APS, I mean, we know that both obstetric and vascular APS can be identified by the presence of antiphospholipid antibodies. But again, this idea that people with women with suspected obstetric APS who are persistently negative for classification criteria may not be appropriately treated. So there is the need to examine non-criteria markers. Now, one of the issues that continually, I think, comes up, at least from what I've seen, is that the issue of low positive APL and obstetric APS. And this is always a subject of controversy and conflicting results, partly because, especially when you're dealing with IgM antibodies. So if a very low positive IgM antibodies, one has to be careful that we can distinguish this non-specific reactivity from actually specific reactivity. So it's necessary to make sure that normal populations, autoimmune controls are examined when labs set their cutoffs. But clearly, we'd like more biomarkers to help clarify the status of patients with obstetric APS as far as other APS. And one of the studies we did looking at criteria and non-criteria APS is seeing how they associate with clinical manifestations. And you can see here that we've looked at the odds ratio for different clinical events and for just overall pregnancy morbidity, beta-2 GP1, glycoprotein 1, domain 1, PSPT-G were associated with pregnancy morbidity. Early pregnancy morbidity was associated with PSPT-IgM, and late pregnancy morbidity was associated with PSPT-G, beta-2G, and beta-2 glycoprotein D1. So this kind of radar plot is very useful to try to see how the various antibodies associated with various clinical conditions. And this was a study that was done in Shanghai by Dr. Tao at Renji Hospital, and they looked again at PSPT in patients with obstetric APS, and they showed that of their patients with obstetric APS, almost 16% were positive for either PSPT-G or PSPT-M. And they looked at the patients with negative obstetric APS, seronegative, and they found almost 46% were positive using PSPT-G and or M. So it clearly shows the value of using PSPT, and it's one of the reasons why many people are a little upset that PSPT was not included in this revised criteria. Now, I mentioned a few times beta-2 domain 1. So beta-2 domain 1, if you're not familiar, beta-2 itself is when it's bound to a plate, or when it actually binds to a cell, it unravels and the conformation changes. So it has 5 domains. The domain 1 is at the top here, and this is to where antibodies from patients with APS bind to domain 1. But patients also have antibodies that bind to these other domains, and these can confuse the issue. So one of the things we did is we made a test specifically to look at the beta-2 domain 1 and not look at the other ones. You can see here it shows that the domain 1 is a subset of the overall beta-2 glycoprotein positive. And then if you use this to look at patients, we can show there have been several studies that have shown that the beta-2 domain 1 can be shown to be higher in late pregnancy morbidity versus early pregnancy morbidity. So in this study, we looked at the domain 1 in APL carriers, obstetric APS, thrombotic APS, and both. And then when we sat in and stratified the obstetric APS into early and late, you can see clearly the patients that were late pregnancy morbidity had a much higher level of beta-2 domain 1 antibodies. And this was also shown in the study we did in Italy, same conclusion. This is a study that was done in China, again, and looked at beta-2 domain 1 antibodies with thrombosis and adverse pregnancy outcomes. And again, their conclusion simply at the bottom, if you look at the odds ratio with it, anti-D1 had the highest odds ratio for thrombosis and adverse pregnancy outcome. And if you look at the cumulative incidence of adverse pregnancy outcome, and these are all lupus anticoagulant positive patients, it's higher in the patients with high levels of D1. So the idea is that measuring anti-D1 in patients who are with APS, in this case with adverse pregnancy, recurrent pregnancy loss, seems to help stratify the patients and may inform on how to best treat those patients. Now, if you look at the comparison in this chart, we compared the D1 and criteria markers odds ratio for pregnancy morbidity. And you can see the odds ratio is the highest for lupus anticoagulant, 16.41. But then it's followed by the beta-2 domain 1, 12.12, and then followed by triple positive, which is somebody who's positive for anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein. So there have been some scores, I won't do it here, where Atsumi and his group have proposed that beta-2, the domain 1 should be used initially for helping to stratify patients. And one of the things I said, we're still looking for new biomarkers for RPL and as far as APS itself. But in this particular study, I won't go through all of this. I don't expect you to read all this, but this is just the idea that people are now applying these new machine learning techniques and the proteomic techniques to look at all the genes in patients, in this case, patients with RPL and controls, and look for the differentially expressed genes, who's downregulated, who's upregulated. You can show here in this volcanic plot, and then try to identify potential markers for recurrent pregnancy loss. So these people identify these four markers here. Doesn't matter what they are, just you can see that they could show differences between them, and it looks very nice, but we really need further studies to actually show whether they actually work in real life. In this case, they look promising. Another thing people are doing to try to stratify patients, an idea of stratifying is to group people with these machine learning techniques by similarities between patients. And by looking at these different groups, then you can decide, you can look at the particular groups and try to identify what's causing that what's similar in that group, are the different disease mechanism, progression, biomarker profiles. And you can see there's been 3 studies that have been done and all come up with this similar conclusion that you can group patients into obstetric group, arterial thrombosis, cardiovascular risk group, venous thromboembolism group. And the same thing here. This one is primary APS, SLE, obstetric. And then this other one here also has another group that they group the things into obstetric group. So this is a very promising way to group the patient and then be able to look more carefully for how we can identify them. So I'm looking for other things. I mean, one of the things we always measure in autoimmune disease is ANA. It's whether it's useful in pregnancy loss, I think is still a little unclear because it is relatively unspecific. But clearly, there have been a number of studies. It was just a 2023 meta-analysis just done at 20 studies, and they said there was 3 times higher risk of RPL in ANA positive patients compared to ANA negative. So one of the questions I have thinking about is if we were to follow up some of these patients, if we were to actually look at the specificities, could we find some further markers that would be useful to routinely evaluate? Cytokines are involved in messaging within cells. They're clearly involved in establishing maintenance of pregnancy. Dysregulation might clearly be a factor in recurrent pregnancy loss. We really don't know very much about it at this point. There have been some new studies that have recently appeared. One of the problems with measuring cytokines in both RPL and other places is the fact that it's been difficult for clinical labs to routinely measure cytokines. So finally, for my last slide here, to detect everybody, I hope you understand, or I got across the point, to detect everybody with APS, you need to look at multiple biomarkers. We'll continue to look for new biomarkers and assess their value. There'll be increased focus on stratification analysis of patients with current and new biomarkers, maybe adding microbiome, other omics to it. Understand their own genetic variation and the risk of recurrent pregnancy loss. Assess the value of cytokine profiles for risk assessment and pregnancy morbidity. Use machine learning, artificial intelligence to combine biomarker clinical data to develop precision medicine models for better diagnosis, prognosis, management, and determine which analytes would make the most ideal multi-analyte platform panel for routine evaluation and monitoring of risk of recurrent pregnancy loss and APS also. 谢谢。
非常有启发，我觉得赵主任给我们请进了这样一位知名的一个资深免疫性疾病的资深学者，来给我们讲解了他的一些，主要是他的诊断方面的一些策略，他们在那个自身 APS 综合症的一个定义的演变，怎么样一步一步来，他的一个诊断这个标准的一个更改，它的原因是什么？为什么要做这些更改？以及在它的分类标准和诊断标准方面的差别，其实这一点我们临床医生可能一开始不是那么重视。其实它分类标准和诊断标准它的用途是不一样的，有些是用于临床研究纳入更标准的病人，而且诊断标准是可能它的更松一点，可以纳入更多的病人来用于临床，就是有些是用于科研。 临床实验，有些是用于临床病人的诊治，所以我们以后在采纳标准的时候，我们根据我们的不同的临床用途，要注意到它的一个标准，它是有差别的，这个对我的启发也非常大。那么还有呢，就是在于它的诊断标准的 APS 诊断分类诊断标准，它还进行了它的敏感性和特异性的一些探讨，以及在临床研究方面的应用。还有它的研究方法上面的一些新的化学发光法和以往的 ELISA 方法的一些研究方法的一个比较。总的来说是非常有收获。那么因为它是远程的，没有办法提问啊，非常可惜。以后